Good morning. My name is Graham Mankies from the University of Cape Town in South Africa, and my co-chair is Sevtap Arikan Agdagli from Ankara in Turkey. And it's a great honor to introduce this morning's keynote lecturer, Professor Tom Harrison. Tom studied natural sciences at Cambridge University and then medicine at St. George's in London before doing his ID training in London and Boston. He then trained in the lab of Stu Levitz in Boston, investigating host defenses against Cryptococcus neoformans. He returned to the UK in 1997 and obtained a Wellcome Trust Fellowship. And over the past 25 years, Tom has developed and led a research program that has been successful in advancing knowledge in the field of cryptococcal meningitis prevention, diagnostics, and treatment. He developed a technique of serial quantitative cultures of Cryptococcus in the CSF that enabled phase 2 evaluation of novel treatment strategies for cryptococcal meningitis. And through phase 2 and 3 trials that he has led or co-led, firstly in Thailand and then with a network of investigators in Africa, the teams have developed more efficacious and safer treatments for cryptococcal meningitis in people living with HIV. And the findings of these large trials have been so compelling that they've been rapidly incorporated into WHO guideline updates and led to the improved outcomes for patients globally. Tom is now the Professor of Infectious Diseases and Medicine at St. George's in London and the lead for the Centre for Global Health there. On a personal note, I've had the privilege of collaborating with Tom for 20 years now. And what has always struck me about Tom is that his research program is underpinned by a deep commitment to improving outcomes for people affected by this condition in the very poorest countries of the world. He has a considered approach to the ethical aspects of his research and the welfare of the participants in the trials, and his commitment to equitable and respectful collaborative working relationships and advancing the career growth of junior investigators. And so with that introduction, I'd like to hand over to Tom, and we're really looking forward to his keynote lecture today entitled A Revolution in the Management of Cryptococcal Meningitis.
Okay, thank you very much, Graham, for the kind introduction, and thank you very much to the organizers for the invitation. And I'm really very honored to be able to give this keynote lecture this morning on behalf of a really fantastic team of collaborators that I've had the privilege of working with over the last years. So these are my disclosures. And this was the plan. For those of you not so familiar with this field, I'll give just a very brief introduction about the organism and the disease epidemiology, and then for the most of the talk, take you through a program of work aimed at optimizing our antifungal therapy for patients with cryptococcal meningitis. And then in a second part, also talk about earlier improved diagnostics and how this has helped us develop a screening and preemptive treatment strategy to try and prevent the development of meningitis in the first place. Because of time limitations, I won't be able to talk about some other very important aspects of managing patients with cryptococcal meningitis. For example, the common complications of raised CSF pressure and cryptococcal immune reconstitution syndrome, and the optimal timing of starting or restarting antiretroviral therapy in these patients. But I think suffice to say that we've also made some considerable progress also in those areas. So what about the organism Cryptococcus neoformans and the related Cryptococcus gattii? It's a fascinating organism about which we actually still have much to learn. It's an accidental pathogen. Essentially, this organism is an environmental saprophyte of the order Tremolales of wood-rotting fungi. It's found in eucalyptus trees, in mopani trees, and other trees, and in avian excreta. And it's the only serious human pathogen of all the basidiomycete fungi. So I think really speaking to the rarity of this type of accidental pathogenesis. The organism has certain features, notably the polysaccharide capsule, the ability to grow at physiological temperature and at low lysosomal pH, and a lacase enzyme, which allows it to be both an extracellular and an intracellular pathogen of mammalian hosts. Now we think exposure via inhalation is very common, perhaps even universal in early life, but human disease and dissemination to the central nervous system usually only occurs in the context of significant immunosuppression, particularly, of course, late-stage HIV infection or a number of other rare immune genetic defects. So the pictures here show collection of samples from Mopani trees in southern Africa. The map shows the Mopani tree belt in southern Africa. That is a human macrophage engulfing a number of cryptococcal cells. And then on the right, the India ink preparation from a patient with cryptococcal meningitis, showing the fungal cells surrounded by a thick polysaccharide capsule. So, in fact, there's a lot still to be learned about the precise circumstances and frequency of human exposure to this organism. But what we do know is the devastating impact it can have on human health. And this shows you the latest numbers in terms of estimate of global burden of HIV-associated cryptococcal meningitis. So still in excess of 100,000 deaths per year, 1 in 5 of all HIV-related deaths. In fact, that proportion has crept up in the latest estimate from 15 to 19% of all AIDS-related deaths related to cryptococcal infection. The vast majority of the burden is in sub-Saharan Africa, where with prior treatments, the mortality was probably considerably in excess of 60%. So in fact, Cryptococcus is by far the commonest cause of adult meningitis across southern and East Africa, as shown by these data from Cape Town and Kampala. And this situation has not changed in recent years. And the other thing that hasn't changed is the total number of cases. Outside of South Africa, in sub-Saharan Africa, there hasn't been an appreciable decrease in cases despite increasing access to antiretroviral therapy. The total number of cases unchanged, but well in excess of half our patients have now had antiretroviral therapy in the past, but have persisting low CD4 counts due to cumulative small annual % loss from care and, of course, also the possibility of antiretroviral resistance. So I think it's now widely appreciated that to further reduce HIV deaths, we need to address the complications of advanced HIV disease, including cryptococcal meningitis. And this recognition, of course, is behind the efforts of the WHO and many other players to improve the care for patients with advanced HIV disease. So where do we begin? The prior long-standing, in terms of treatment, the prior long-standing international gold standard of therapy was 2 weeks of amphotericin B deoxycholate plus flucytosine. And this was based on the mycosis study group trial led by Charlie Vanderhorst and colleagues, published in the New England Journal over 20 years ago. It was supported by work from our own group, Anne-Marie Brouwer, working in Thailand in a study published in The Lancet in 2004, where we showed at that time that combination led to the most rapid clearance of infection. And then in an important study in Vietnam, Jeremy Day and colleagues showed the survival advantage of the combination of amphotericin B and flucytosine. But the problem, of course, is that amphotericin B deoxycholate is really very toxic and difficult to administer, particularly in low-resource settings. So there's this thrombophlebitis, as shown in the photograph, not uncommonly leading to life-threatening secondary bacterial sepsis. There's very significant anemia, over 2 grams drop in hemoglobin over a 14-day course of deoxycholate amphotericin. That's very clinically significant, of course, particularly if you start with a low hemoglobin level, as many African patients with cryptococcal meningitis do. Then very significant renal impairment, life-threatening potassium and magnesium wasting, if that is not very carefully monitored and managed. And in addition, of course, flucytosine has simply not been available until recently across Africa. On the other hand, what has been available, fluconazole monotherapy, is essentially a much weaker treatment, such that patients on fluconazole monotherapy keep dying, and by a year of follow-up, then less than a quarter of patients have survived. So the underlying rationale for the trials that we've done over the last years in collaboration, the ACTA and Ambition phase 3 trials, was on this basis and built on a series of phase 2 studies aimed to design new regimens that could be more feasibly implemented, would be less toxic than this international gold standard of 2 weeks deoxycholate and flucytosine, but would be a whole lot more effective than fluconazole monotherapy. And the approach we took for this was to develop and use a new phase 2 study endpoint. We called it the early fungicidal activity that we first used in a study in Thailand. In fact, the study I've referred to, and the top picture there shows Anne-Marie Brau with Nick White and Non Luck in Ubon Ratchathani Hospital in northeast Thailand. But when we took this technique to Africa, and in fact this was the work of Tihana Bicinic with Graham and his colleagues at Uster Hospital, and that's the front of Uster Hospital there, and Tihana talking to the lab manager, Tony Williams, at Uster Hospital at the time. When we took this technique, in an observational study at Uster Hospital, we understood immediately why the results with fluconazole monotherapy were so poor. So just to explain these graphs to you, on the x-axis you've got the day of treatment, the first 14 days. On the y-axis you've got the log colony-forming units of Cryptococcus per mil of CSF, based on serial lumbar punctures and quantitative cultures of the CSF. And so each line is the response of an individual patient, and for the early fungicidal activity, you can take the average slope of those lines on a particular antifungal regimen. So you can see with fluconazole at the then standard dose of 400 milligrams a day, you've essentially got a static type of an effect, not much control of infection, compared to what can be achieved with amphotericin B therapy. So the first step was to try doubling and tripling the dose of fluconazole. And this was work done in Mbarara in Uganda by Nikki Longley and Conrad Muzura and Kabanda Tasira and colleagues in Mbarara. And what we found was clear evidence of a dose response with more appreciable clearance of infection with the higher doses, and no hint of any increased toxicity at these higher doses given for this relatively short period. But you can also see that the clearance with fluconazole at 1200 is still some way short of that observed with amphotericin B deoxycholate. So in a second set of studies carried out at this time, we were invited by Charlie van der Horst and Mina Hossanipur to collaborate with them at the UNC project in Lilongwe, Malawi. Together we performed a phase 2 randomized control trial adding flucytosine to the high-dose fluconazole. And as you can see there, with that combination, oral combination, then we were approaching the rate of clearance of infection seen with amphotericin B alone. In addition, patients on combination had improved survival compared to fluconazole monotherapy, even though this was a relatively small phase 2 study, not powered for clinical endpoints. Furthermore, in very elegant work, Neil Stone doing his PhD with Tihana and working with Professor Mfinanga in Tanzania showed that the oral combination, in addition to increasing the rate of clearance of infection, prevented the development of fluconazole resistance. And they did this by taking the cerebrospinal fluid direct from lumbar puncture, plating it onto agar which either contained or didn't contain fluconazole. And if you do that, even at baseline, there's a small percentage of fungal cells that will grow through the fluconazole, so-called heteroresistant cells. And if you follow those cells, those populations over time, what they were able to demonstrate was that on fluconazole monotherapy, that heteroresistant population is selected for such that it becomes the dominant population and leads to treatment failure. Whereas with the combination of fluconazole and flucytosine, then both the total and the resistance subpopulation are effectively suppressed. And Neil and Tihana, working with Judy Berman in Israel, went on to show that the most common mechanism of this heteroresistance was aneuploidy on chromosome 1 of the fungus. So this was the first experimental regimen that seemed very promising that we wanted to take forward to phase 3 studies. The other experimental regimen we took forward was shortening the course of induction with the amphotericin B deoxycholate. And the idea behind this was that we know this drug has a very long half-life, perhaps in particular in the brain tissues. And we know that the side effects become particularly prominent during the second week of treatment. So if we gave a shortened 1-week course, maybe we could get all the efficacy and miss out on some of the important toxicity. And this was backed up by a subsequent cohort study led by Konrad Musura in Umburara, where in fact the patients got just 5 days of amphotericin B deoxycholate on top of high-dose fluconazole, and in an early fungicidal activity study. As you can see, the rate of clearance here is good, as you'd expect with amphotericin B on board, but the particular point is that there's no decrease in the rate of clearance of infection in the second week, even though the amphotericin B is no longer being dosed, supportive of this concept of prolonged efficacy due to prolonged half-life, long half-life of the drug. In addition, in support of this concept, careful animal model PK/PD work from the group of William Hope in Liverpool, they showed in both murine and rabbit models that even just 3 days dosing with deoxycholate appeared to be equivalent to 14 days daily dosing in murine and rabbit models of cryptococcal meningitis in terms of the CFU counts at the end of 14 days. So again, supportive of the concept that amphotericin B can concentrate and remain in brain tissue and have prolonged effect. So that was that was the background to the first phase 3 trial, which was the ACTA trial. The 2 experimental strategies were, number 1, the optimized oral combination, and number 2, amphotericin B deoxycholate, but given for 1 week instead of 2 weeks, against this international standard of amphotericin given for 2 weeks. And in the ACTA trial, we asked a second very important practical question, which is what is the best partner drug to give with amphotericin? Is it the traditional flucytosine, which, however, is not available in Africa at this time, or was it the fluconazole that had become the default partner drug? And so in the 2 amphotericin B strategies, patients were additionally randomized 1-to-1 to receive either fluconazole or flucytosine. So this was the ACTA trial, considerable undertaking in 4 countries, 9 hospitals, 2 funders, until the AMBITION trial, the largest trial in cryptomeningitis. And this shows you the headline result from the trial. And the result was that all 3 of these strategies performed equally well. These mortality curves, in fact, the blue line is the oral combination, the red line is the 1-week amphotericin, and the green line is 2 weeks amphotericin B strategy. So no appreciable difference between these strategies. And it was interesting because the oral combination performed very well, even though the rate of clearance of infection, as shown here, was less rapid with the oral than with the 2 weeks amphotericin B. That less negative number is a less rapid clearance of infection. As we'd expected, the 1-week amphotericin B gave just as rapid clearance as 2 weeks amphotericin B, as we'd seen in the phase 2 studies. What was different between the strategies, though, was also the tolerability, in particular in terms of the anemia. So much less severe anemia with 1 week than 2 weeks amphotericin B, and even less on the oral regimen, as shown there in the proportion with grade 4 anemia, or else as assessed by the mean change in hemoglobin over 2 weeks, and also in the need for transfusion within the trial. In terms of the partner drug, the best partner drug to give with amphotericin B, there was a clear result in favor of flucytosine. So flucytosine in red and over fluconazole in the blue. So highly statistical survival advantage with flucytosine as the partner drug, which mirrored also increased rate of clearance of infection with flucytosine as the partner drug. So in ACTA, if you actually divided the results into the 5 different treatments given within the trial, then by some way, the best result was seen with 1 week amphotericin B deoxycholate and flucytosine in the green curve there. And in fact, that was just 24% 10-week mortality. So really a step change improvement compared to prior trials of cryptococcal meningitis in Africa, and actually statistically significantly better than 2 weeks amphotericin B and flucytosine, as shown there. So that was 10-week outcome. Some people asked us for longer-term follow-up. So Cecilia Kanyama, working with Sheila Malloy and colleagues in Malawi, had complete follow-up to 12 months for over 230 Malawian participants in the trial. And it was gratifying to see that the benefit of the 1 week deoxycholate plus flucytosine regimen was very much maintained right through to 12 months, as shown there in the purple line. So we felt the results of ACTA reflected a balance between the rate of clearance of infection and the tolerability. We had just as rapid clearance with 1 week as with 2 weeks, and much less side effects. With the oral regimen, was very well tolerated and was non-inferior, even though the clearance was less rapid. So we shared these results with colleagues at the WHO prior to publication, and so that the WHO were able to come out soon after publication of the ACTA results with revised guidelines. And they're recommending the 1 week amphotericin B deoxycholate and flucytosine regimen as the preferred regimen, and with the optimized oral combination regimen as a second-line regimen if amphotericin B was not available. But obviously for both of these regimens, we needed new wide access to affordable generic flucytosine. So in addition to sharing the results with the WHO, we shared the results with an organization called UNITAID, and Angela Lois from our group took the lead in this with others, with many others. And the result was a program from UNITAID to support advanced HIV disease in more general, but specifically to support generic flucytosine and also the diagnostic tests we needed in 7 key countries. And this was through the Clinton Health Initiative. And I'm happy to say that there are now 2 manufacturers making WHO-approved generic flucytosine, and the cost has halved since the ACTA trial was published in 2018, from $1.30 per tablet to around 65 cents per tablet. And of course, the health economics aspects are absolutely key to implementation. And within the ACTA trial, we had an embedded health economic analysis. And if you take the few countries that prior to the trial were using 2 weeks amphotericin B deoxycholate, relatively few countries, but in particular South Africa, Botswana, and Zambia, were using 2 weeks amphotericin B deoxycholate, usually with fluconazole. For these countries, switching to the 1 week deoxycholate plus flucytosine regimen saved lives, an average of 14 lives per 100 patients treated, but also saved money, $400 per patient or $42,000 per 100 patients treated. So in these settings, the 1 week regimen was, in health economic terms, dominated, saving both lives and money. But of course, in much of Africa, the more relevant comparison was the economics of adding flucytosine to fluconazole therapy. And of course, fluconazole was not an arm in the ACTA trial, but actually we got pretty good cohort data on the outcome of fluconazole monotherapy. It's around 55% 10-week mortality. So this chart shows you the cost per life year saved of adding flucytosine to fluconazole for cryptococcal meningitis treatment, depending on the cost of flucytosine, and as I say, we're now down to about 65 cents per tablet, and the 10-week mortality with fluconazole, around 55%. So we're in that blue shading area, somewhat less than $40 per life year saved by using the combination instead of fluconazole monotherapy. So highly cost effective. And then the last bit of implementation subsequent to the ACTA trial results was this National Flucytosine Access Program in South Africa, which was initiated by MSF, the Southern African HIV Clinician Society, Nelesh Govender pictured there, and his colleagues, and with the support of the Department of Health. So flucytosine was introduced across sentinel sites in South Africa and used in the 1-week deoxycholate plus flucytosine regimen. And it was pleasing to see that in use in practice, and these numbers are quite large, you see from the ends there, there was, for the first time in Nilesh's long-running surveillance program, really a step change in the in-hospital mortality. So this is in-hospital mortality, reducing from 37%, reflective of the prior standard of 2 weeks amphotericin B and fluconazole, to 24% with the 1-week deoxycholate and flucytosine regimen. So basically mirroring the benefits seen in the ACTA trial in more routine setting. So now I want to move on to the subsequent studies which were looking at the use of ambisome to treat cryptococcal meningitis and the AMBITION trial. So liposomal amphotericin, of course we know this drug is not necessarily per se more active, but it's certainly much less toxic than deoxycholate formulation, less renal impairment, less anemia, and an even longer half-life and excellent brain levels. So we felt even perhaps better suited than the conventional drug to the idea of short, high-dose induction treatment aimed at loading up the brain compartments. And of course, if just one or a few doses could be shown to be effective, it could be a very cost-effective and feasible regimen to implement widely. In support of the concept, again, was work from William Hope's group in Liverpool. This is murine data from mice given a single high dose of liposomal amphotericin B. And just to emphasize the half-life of this drug in brain tissue, 133 hours. So you really could imagine that a single dose of this drug could have a very prolonged beneficial effect in patients. As in ACTA, though, we did a phase 2 study prior to moving to phase 3, and this was with Joe Jarvis in Tanzania and Botswana, and we looked at a single high dose of ambisome, 10 milligram per kilogram on day 1, or 2 doses with a backup dose on day 3, or 3 doses with backups on days 3 and 7, compared to the standard daily dosing of liposomal amphotericin B, on top of the fact all patients got, in addition, high dose of fluconazole. And this shows you the results of the phase 2 study. And what we saw was that all the intermittent regimens of liposomal amphotericin B gave equivalent clearance of infection, including the single dose regimen. And what we saw immediately was that this formulation, of course, was much better tolerated, in particular in the African context, much less severe anemia than we'd seen in ACTA or had been seen in prior amphotericin B deoxycholate trials. So this was the basis of moving on to the AMBITION phase 3 study. And here we took the single high dose of ambisome and backed it up with the optimized oral backbone of high-dose fluconazole and flucytosine, which have performed very well even on its own in the ACTA trial. And we compared it against the new WHO standard of 1-week deoxycholate with flucytosine, again in an all-cause mortality, 10-week mortality endpoint, clinical endpoint trial. And the top right is Joe, and the other photograph shows David Lawrence, the lead clinician, and Nabila Yusuf and Philippa Griffin, the key kind of core team on the trial. And then obviously, again, a wonderful team of PIs and site teams to complete this trial. This shows you the headline result from the AMBITION trial. This was 407 patients analyzed per arm. No patients lost to follow-up within the first 10 weeks. And in terms of the mortality result, 10-week mortality, 24.8% for the ambisome, single high-dose ambisome regimen, 28.7% for the 1-week regimen. So whatever analysis you use, easily meeting our non-inferior criteria. And also, incidentally, confirming the very good performance of the 1-week deoxycholate plus flucytosine regimen with a sub-30% 10-week mortality, which, as I've mentioned, is a step change better than prior antifungal treatment trials in Africa. This shows you the Kaplan-Meier survival curves and the non-inferiority analyses graphically. And this shows you the fact that we were able to match the rate of clearance, the early fungicidal activity, with a single intravenous dose of ambisome. We were able to match the clearance seen with 7 daily doses of amphotericin B deoxycholate, so no difference in rate of clearance of infection. Again, what was different was tolerability. So, and I've just picked out there the change in hemoglobin over the 2 weeks. With the control 1 week regimen, that was 1.9 grams. That's almost exactly the same number as we saw with that regimen in the ACTA trial. But the ambisome regimen, really very clean, hardly any drop in hemoglobin. And that was also reflected in the other measures of tolerability, renal impairment, in particular, and also, I think importantly, the thrombophlebitis, as you would expect with only a single intravenous infusion required for this regimen. So the conclusion was a single high-dose ambisome regimen was non-inferior, same clearance, fewer adverse events, and even more practical, easier to administer, better tolerated treatment for HIV-associated cryptococcal meningitis. But now, of course, we needed access to ambisome as well as to flucytosine. Again, these results were shared with the WHO prior to publication, such that the WHO were able to analyze and come out with revised guidelines shortly after publication of the trial last year, recommending the single high-dose ambisome regimen as the first-line regimen, with, importantly, though, backup regimens, the 1 week deoxycholate regimen, if no liposomal amphotericin is available, and if no ampho formulation at all is available or able to be given, then the oral combination as from ACTA. So again, what about the health economics? Because again, within the trial, we had a formal health economic analysis. And the fact is, although liposomal amphotericin B is of course, per se more expensive, in terms of the total cost of treatment, it's actually a relatively modest increase in total cost, as shown here from $1,100 to $1,200. This is cost from Malawi, and with an implementation monitoring scenario where some of the monitoring is not required in the single high-dose ambisome arm because it's so well tolerated. And if you do the calculations, then the cost per life year gained with the single high-dose ambisome regimen, again, very modest, just $80 per life year gained. And in fact, the analysis showed that this regimen could be, in some circumstances, cost-saving, particularly if the median admission of patients was shortened, even by 1 or 2 days in some settings. It could end up cost-effective, cost-saving. And of course, also, if the cost of flucytosine were further reduced or the cost of liposomal amphotericin B further reduced. So also, in addition, of course, it was excellent that Gilead welcomed the results of this trial and have continued to commit to provide ambisome at preferential pricing for the treatment of cryptococcal meningitis in high-burden countries. So what about guidelines and practice? Well, following the WHO lead, then a number of countries have already updated their country guidelines to adopt the ambition regimen, particularly, of course, the countries involved in the trial. And I think that speaks to the value of multinational phase 3 trials. And it's already, the regimen is already in routine use in a number of these countries, and this list is increasing, enabled by that UNITAID CHI program, and now, importantly, also by the Global Fund. And I think with some considerable foresight, the CHI UNITAID program, as well as introducing generic flucytosine, started procurement of ambisome, perhaps looking forward to the results of the ambition trial, so that these drugs were in place in some countries even as the trial finished. But importantly, now the Global Fund will support procurement of these drugs if countries request them. And that's obviously vital in terms of providing a long-term access program to the drugs. In addition, we hope, and I know my colleague Nilesh from South Africa is hoping, working with colleagues and also I think Gilead, to have an access program in South Africa as there was for flucytosine. So in fact, there's a number now of implementation and training initiatives. There's the Share CM program led by Joe Jarvis and David Lawrence with support from the CDC. There's the Imprint program. This is a UK NIHR global health group on HIV-associated fungal infection led by Nilesh and Joe, which includes collaboration with the MSF with an AMBI-1 implementation study. And there's the Continued Unitaid CHAI program, the work of colleagues in the CryptoMag advocacy group, an important program led by DNDi on 5FC access and modified release 5FC, the work of other major NGOs, and now also increasingly country ministries. And I'm grateful to James Conroy from CHAI for making me aware of this data, which is in the public domain, from a group called the ARV Procurement Working Group. And as you can see, this is an umbrella organization that encompasses most of the major funders, including the Global Fund and PEPFAR. And it just shows you the increasing number of countries now which are accessing flucytosine and liposomal amphotericin B through these programs. So in 2021 and then in 2022. And in terms of the amount of drugs being procured, almost a 400% increase in both flucytosine and liposomal amphotericin B procurement. And I was particularly happy to see this comment from the March 2023 report about flucytosine tablets. 2 generic suppliers, Stride and Viatris, with no further supply issues anticipated. And for those of us in this field, that is really music to our ears. People have been advocating for access to this drug for really quite a long time. So I really think there's an unstoppable demand and momentum building around access to flucytosine, ambisome, and better crypto treatment. And now the activists are very much on board, as well as the ministries and everyone in between. And there is some coordination of this effort going on. There was an advanced HIV disease demand creation supply meeting in Nairobi before Christmas, organized by DNDi and Angela Loyce and colleagues. Next week, there'll be another meeting in Cape Town under the auspices of the CDC. And just this lovely picture shows you activists Vuiseka Dubula in the IAS conference in Montreal last year. And for the first time, we had activists at the conference with crypto on their T-shirts. So as I say, I think there's really an unstoppable demand now for better treatment for this disease. So what about the impact? I think we're looking at a significant and importantly sustainable reduction in mortality, which, however you calculate it, has to translate to thousands of lives saved per year. It's interesting to speculate, but it's possible that the single high-dose ambisome regimen may have a greater benefit in routine care than we saw in the trial due to the high level of monitoring and management of the deoxycholate side effects that necessarily we put in place in the course of the trial. But I think it's important that we have these other backup regimens. If there's no ambisome, the 1-week deoxycholate regimen, if it's given safely, has an equal mortality benefit. And if you have no AMPHO at all or no facility to give AMPHO, remember the oral combination almost halves mortality compared to prior fluconazole monotherapy. So the fact is, more of our patients at one moment facing death in hospital from cryptococcal meningitis can actually leave hospital and have a good long-term prognosis, either initiating antiretroviral therapy for the first time or restarting antiretroviral therapy. And any of you interested in this area, I would just urge you to read this excellent paper from David Lawrence and colleagues, which includes some quotes from our patients, their experience of the disease, their experience of participating in the Ambition trial, and obviously a vital perspective for us to understand and to be aware of. As well as being the lead clinician for the trial, David completed an excellent qualitative social science PhD during the trial, interviewing patients and healthcare workers about their experience of the disease and the treatment. So what about a treatment? I mean, what about beyond the Ambition trial? I mean, I think we've just about optimize the use of these three drugs, amphotericin, flucytosine, fluconazole. For further advances, we need to look to the new drugs which are coming out there, and also to immunotherapeutic approaches, which we shouldn't give up on. And in terms of new drugs, I just draw your attention to this one, APX 2039. It's the new class of antifungal developed by Amplix and now owned by Pfizer. And the very, very encouraging in vivo animal model data from John Perfect's lab. And I really hope that this compound can be taken forward to clinical development for the treatment of patients with cryptococcal meningitis. But the fact is, whatever treatment we give, some patients are still come just too late. So what about earlier diagnosis and/or prevention? And I'm going to just change for the last part of this talk to talk about this. The fact that we do now have a much better diagnostic test for cryptococcal disease, which enables earlier diagnosis of all patients and makes feasible a strategy for prevention. And what I'm talking about is screening for cryptococcal antigen before patients get sick, and preemptively treating those who test cryptococcal antigen positive with antifungal treatment to prevent them becoming ill. So the problem is with cryptococcal meningitis, of course, the first thing you have is headache, and that's so non-specific and so common that, of course, it's easy to imagine patients are not immediately referred to hospital for a lumbar puncture. By the time they do get to hospital, it may be too late. So this point-of-care lateral flow CRAG test, developed by ECCMID, and critically with antibodies in the strip from the laboratory of Tom Kozel in Reno, Nevada, has been really transformative, a game changer in our field. And you could say that the polysaccharide capsule of the organism, although it's a major virulence factor of the organism, is also in one sense an Achilles heel, because it's shed in the body tissues, in the blood, in the cerebral spinal fluid, even in the urine, and is the basis of this very specific and very early, even before patients get sick, point of care test. All of you in the field will recognize this ECCMID test by now. It's a simple 10-minute dipstick test meeting all the WHO assured criteria for a test suitable for global rollout. But as well as being highly convenient, it's also actually a better test. And that's because of the antibodies. The combination of two monoclonal antibodies from Tom Kozel's work, chosen to give good detection across the serotypes of Cryptococcus. So there's no gaps in the performance of this test, and a sensitivity of 2 to 5 nanograms of polysaccharide per ml, as shown there. So you can see actually in the order of 100-fold better sensitivity with this test than with the old laboratory-based latex agglutination test for the detection of cryptococcal antigen. So, as I say, screening and preemptive treatment. What we're talking about is patients at risk of crypto, that's patients with low CD4 count, in different cohorts, somewhere less or more than around 5% of patients who are currently well with these low CD4 counts may test positive on a blood CRAG test. They can be preemptively treated with antifungal therapy prior to antiretroviral therapy, prior to getting symptomatic meningitis. And it's based on the fact that we understood this antigen is detectable in blood well before patients get sick. And really a landmark retrospective study carried out by Joe Jarvis with the colleagues in Cape Town, which took an advantage of a bank of blood samples which had been kept stored in Cape Town from patients initiating antiretroviral therapy in some of the earliest antiretroviral therapy program in South Africa. And that bank of samples was tested retrospectively, and the study showed how good this screening test was in terms of its power to show who was at risk of developing meningitis if you were CRAG positive, and just as importantly, if you were CRAG negative, that you had almost zero risk of developing cryptococcal meningitis if you were CRAG negative and started antiretroviral therapy promptly. So based on that, and also very convincing cost-effectiveness modeling, and of course on the development of the dipstick test that made the whole thing feasible, then screening programs have been introduced. And the prospective data suggests that cryptococcal antigen screening in this way does save lives. Perhaps the best data is from this REM-START study led by Professor Mfinanga in Tanzania, Shaba Jaffa, and colleagues in Zambia. And a combination of cryptococcal screening, as I've outlined, and community-based early ART adherence support led to a 28% reduction in one-year mortality in patients entering HIV programs in those countries. And there was reason to believe, when you looked into the data, that we thought about half of the benefit was due to the cryptococcal screening and half due to the adherence support. But this and other prospective studies of screening have shown some common themes. Some common themes have emerged about this screening. One, it does save lives, but CRAG-positive patients identified in screening still have high mortality. And a significant proportion of them, if they agree to have a lumbar puncture, you'll find that their CSF is CRAG-positive, indicative of some degree of subclinical cryptococcal meningitis. And perhaps not surprisingly, the level of antigen in the blood predicts that subclinical meningitis and predicts a higher mortality. So I think the evidence pointing to the fact that we need to study more effective antifungal therapy for these asymptomatic patients picked up through CRAG screening in the context of a bundle of other diagnostics and ART adherence support for all these patients. And this just shows you this ongoing higher mortality in CRAG-positive patients from the REM-START study and the two prospective studies from South Africa. So 25 to 30% mortality despite fluconazole in CRAG-positives, around 15% mortality if you're CRAG negative. This shows you data from Rachel Wake, working again with Nilesh Govender in South Africa, the association between the blood CRAG titer and your CSF CRAG status. So obviously with higher blood titer, more likely to be CRAG positive in the CSF. And this just shows you the work, Rachel Wake's work, showing that within the screening program in South Africa, those patients who are still dying despite fluconazole therapy, many of them are dying of cryptococcal-related causes. And she showed this through minimally invasive autopsy studies. Crypto was an immediate or contributing cause in 60-odd% of the cases at least. So I'm pleased to say that there are actually now two ongoing phase 3 studies looking at enhanced antifungal therapy for CRAG-positive patients. The EFFECT trial, looking at the combination of fluconazole and flucytosine, as used for symptomatic patients in ACTA, versus the current standard of fluconazole alone. This is being led by Nilesh and Sheila Malloy and Professor Mfinanga, embedded in CRAG screening programs in South Africa and Tanzania. And then the Acacia study that's actually been ongoing for a longer period by colleagues David Mayer, Radha Rajasingham, Elizabeth Nalintaya, and the Makerere, Minnesota group, looking at single high-dose ambisome in these patients, in addition to the fluconazole versus the fluconazole alone standard of care. And I really hope the combined data from these studies will help to finally realize the full benefit of the screening and preemptive treatment strategy. So I want to kind of start to wrap up here, and I've got a couple of reflections. The first is, on this program of work, I think it's fair to say that the phase 2 studies enabled by the early fungicidal activity endpoint were absolutely critical in helping us to efficiently, in terms of time and money, select the regimens for phase 3 and improve the chances of our success in the phase 3 trials. And of course, they enabled us to triple the dose of fluconazole, reduce the amphotericin B to a single infusion, and showed indeed the critical importance of flucytosine in all the best performing regimens. I think also the embedded economic analysis have been very important in helping to drive uptake. And I'd argue that academic and collaborative with industry trials can play an important part in optimizing our treatments through optimization of dose and combinations of agents from diverse manufacturers and drug scheduling, but also that there's the opportunity for some of this work to be done in an earlier stage of drug development, even at preclinical stages. In terms of the widening impact, I'm happy to say that there's now ongoing trials of single high-dose liposomal amphotericin B approach being tested in HIV-associated histoplasmosis, and Alessandro Pasqualotto and colleagues presented very encouraging preliminary data at ID Week last year, and similar studies also in the planning from Tu Ly and colleagues working in talaromycosis in Vietnam. Could we use some of these same approaches to selecting and optimizing through in vitro, in vivo, and phase 2 studies, combinations of the old and the newer drugs, for that matter, coming through for other serious life-threatening fungal infections, including invasive candidiasis and aspergillosis, as one important strategy to try to mitigate against and prevent further resistance and potentially increase efficacy, and really address the very urgent threat of increasing antifungal resistance in these pathogens is posing for us currently. So I want to acknowledge, of course, the phase 3 trials are the result of the work of an enormous number of people across the study sites, and these are the acknowledgements for the Ambition trial. And these are the acknowledgements for the ACTA trial. And these are acknowledgements of particular colleagues that I've had the privilege of working with over the years. And also I'd like to acknowledge our funders, of course, who are essential to carry out the work. And I just want to leave you with one quote from the article I mentioned from David Lawrence and colleagues from a participant in the Ambition trial. So I won't read that out, but perhaps we can leave it up for a minute or 30 seconds or so whilst we have any questions. And I will finish there and be happy to try to answer any questions. Thank you very much for your attention.
Thank you very much, Professor Harrison. Great talk indeed, and very impressive data. Before we move on with the questions and comments, I have an announcement regarding the fireplace session for this keynote lecture. It will be at room 16 at first floor at 12:30, and there are still free seats available. If you're interested, please hurry and just be there, because the participants will be let until maximum capacity of the room is reached. So as for the questions, there are many regarding availability of the drugs. Actually, you addressed these during your presentation later, but if you want to emphasize once again, if liposomal amphotericin B is not available, if flucytosine is not available, what can we do? Are many of the questions as far as I can see here.
Yeah. Well, I mean, I think that's important why we have, this is why it's important that we have a range of regimens. So if we don't have ambisome, then the 1-week deoxycholate is a highly effective regimen if it's given safely and monitored carefully. And if you have no ampho at all, then you can use the oral combination. As I say, halves the mortality compared to fluconazole monotherapy. So I think the sticking point is the flucytosine. Without flucytosine, you really can't move forward. But that is now affordable, as I've explained, and it is available if countries request through these major procurement programs, and hopefully may become even a little more affordable as we go forward, as demand increases.
Yeah, thank you. And one other question is, can we use Ambition trial results for non-HIV cohorts and also for the cryptococcal gut tie infection?
Yeah. Now, on that front, I would urge extreme caution, because the Ambition trial was carried out in HIV-associated cryptococcal meningitis in Africa. So this does not speak to the non-HIV-associated disease, which people in this field will know that's a very different clinical disease. I mean, I think something of the action of these drugs and the PK/PD of these drugs is generally applicable, but this regimen can't be directly transferred to non-HIV populations and out of the HIV setting and the setting in which the trial was done, without careful consideration and almost certainly some additional data. That will be what I would say at this point in time.
Yes, thank you. So I see that we also have questions from the floor, and we can start.
So
Yes, please.
my question has been answered. That are these researches and trials are applicable to the patients who are immunocompromised, not because of HIV, but because of other reasons, like long-term steroids, immunosuppressive therapy, cancer patients, or the people who are not immunocompromised and they get this cryptococcal meningitis. So can we apply the results of these trials in treating those patients, that population? So that was my question, but that has been answered. And then other problem is the availability of this drug is in many lower middle income countries across the world. So I come from a low middle income country where flufenazine and even liposomal amphotericin is not freely available. Yeah. And the patients, so are there any trials, can you suggest data that amphotericin is given, amphotericin is given periodically for a long duration to control the side effects? Because what I have heard that amphotericin has the dose, the cumulative dose is important. Or can we use high dose of amphotericin B, conventional amphotericin, instead of liposomal amphotericin as a therapy, as a like a high dose, and just like not, and just for one high dose, and not the liposomal amphotericin. Are there any trial which suggests a high dose, first high dose of amphotericin B can replace liposomal amphotericin B?
Well, thank you. There's obviously a number of issues related there. Maybe if I just take the shorter course of the deoxycholate amphotericin B. I mean, obviously in the ACTA trial, we went down to 1 week. We haven't gone down further. The animal model data might suggest that it is possible, but you know, you need to do more studies to show that. Maybe on the backbone of an optimized oral combination, you could get away with 3 or 4 days of deoxycholate and it would be very effective. I mean, I think that's very possible, and that could be studied, would be very valuable to study. I think what we've learned about this disease is, for me, the importance is the initial induction period and getting control of the infection rapidly. So then I'm not so keen on very prolonged courses of a toxic drug like amphotericin B. I think once you've got control, then the efficacy of the consolidation and maintenance with fluconazole is really excellent, and obviously that's cheap and safe to give.
Thank you very much. We have time for a couple of more questions.
Congratulations for all your life achievements, mitigating mortality of crypto. The question I have for you is still 1 out of 4 patients will die receiving the short period of Ampho B. What is the clinical and laboratory profile, of patients with HIV and crypto that you would not select for a short period, and how you would tailor the treatment in this subpopulation that you expect that will not respond?
Yeah. No, it's an excellent question. You know, when we've analyzed our data and tried to look, did the shorter treatments work better in the less sick patients, for example? Did the oral combination work better in less sick but not so good in the sick? We haven't seen any evidence of that. These regimens work as well in the sicker patients as in the less sick patients. There's no differentiation of that. But I take your initial point, absolutely. There's still 20%, 25% mortality with this disease. That's why, you know, I moved on to talk about the screening and preemptive approach. I mean, we have to bring the whole treatment paradigm earlier in the course of the disease. And this CRAG diagnostic test, I think, enables us to move in that direction. So I think that's the direction we've got to take. And also to take the community and the patients with us, because, as I say, until now, crypto's been slightly lost in the messaging, and headache is so non-specific. But maybe we could improve that, improve earlier presentation to care if the messaging got out about the significance of headache in the context of HIV and other immunosuppression particularly. So,
Thank you.
Yeah.
Yes.
Thank you very much for this great talk. I just would like to know, is myelotoxicity a problem with flucytosine in the protocol which you use for cryptococcal meningitis?
Yeah. No, thank you very much for raising that point, because it's an important point and it's a concern that many people have had over the years. But you see, we're just using it for 2 weeks in, of course, a historically lower dose than was originally used with flucytosine. And we see really very little in terms of myelotoxicity. There's a neutropenic rate of something like 3-4% maximum. So it's not a serious concern. And you see the survival advantage, massive survival advantage. So really the risk benefit is there to use flucytosine. We do monitor blood counts, weekly. And really, I think the only concern is in patients with renal impairment in whom the 5-FC levels will be elevated. And it's very important, obviously, to dose the flucytosine appropriately according to renal function. But we don't believe that drug monitoring of flucytosine levels is necessary in this setting. In none of our trials have we had drug monitoring of flucytosine levels, and the result is the benefit you see.
Tom, excellent presentation. I was just thinking, in case of asymptomatic antigen-positive cases, fluconazole is usually used. Can you use amphotericin in asymptomatic asymptomatic antigen-positive cases?
Well, for me, that would need studying, because there's a broad spectrum of patients who are antigen positive, and I think there are some patients who probably have a low blood antigen titer, and who move quickly onto antiretroviral therapy. Their risk of disease is probably extremely low, and their risk of mortality. So to introduce amphotericin B-deoxycholate for those patients would be difficult to justify. So I think looking ahead, and there's work going on this, we're probably going to end up stratifying the management approach to these CRAG-positive patients based on the blood CRAG titer. And we do have some tools to look at that now. So if you have a high blood titer, then more aggressive antifungal therapy may be warranted, but we need to do the studies and the evidence. The evidence will come out of the trials, the Acacia trial and the EFFECT trial, because they can be analyzed by blood CRAG titer.
We can have a last very short question, please.
Okay. Thank you very much for a wonderful talk. With all this enhanced or faster fungal clearance, do you predict we'll be able to shorten the time to starting antiretroviral therapy? In other words, have you seen any impact on immune reconstitution with these regimens?
No, it's another excellent question. Now, people in the field will be aware of the very important study of David Boulware and colleagues looking at antiretroviral timing, the COAT study, which showed that antiretroviral therapy at, I think it was a median of 8 days, was not beneficial, led to higher mortality compared to the normal window that we use, 4 to 6 weeks. In that type of a study, you only study 2 time points, and of course, it's possible that 4 weeks or sometime during the 4th week or even at 3 weeks may be safe and okay. But it's quite hard to power those studies to look at that more closely. And any attempt to go shorter, personally, I feel that we could probably go a week shorter in many patients, would be in the context of, as you say, highly fungicidal initial regimens that reduce the load quickly.
Okay, we're at the end of the session. I'm sure there will be more questions during fireplace session. Thank you very much once again for this excellent keynote lecture. And thank you all for your attendance and participations, and I close the session.